Hi everyone, welcome to our YouTube channel MediMentorz. In this video, we will be seeing about the lymphoneoplasms. First, let us see about the classification of WBC neoplasms. The WBC neoplasms are broadly classified into lymphoneoplasm and myeloneoplasms. In lymphoneoplasms, we have non-Hodgkin's lymphoma and Hodgkin's lymphoma, whereas in myeloneoplasms, we have acute myeloid leukemia, myelodysplastic syndrome, and myeloproliferative disorders. The non-Hodgkin's lymphoma is further classified into B-cell neoplasm and T-cell neoplasm. In B-cell neoplasm, we have pre-B-cell neoplasm, which includes acute lymphoblastic leukemia, whereas in peripheral B-cell neoplasm, we have chronic lymphocytic leukemia, mantle zone lymphoma, follicular lymphoma, diffuse large B-cell lymphoma, Burkitt's lymphoma, and marginal zone lymphoma. In T-cell neoplasms, we have anaplastic large cell lymphoma, adult T-cell leukemia, and mycosis fungoides. In this video, we will be seeing about the ALL and CLL, which are neoplasms of lymphoid series, which consists of the cells which are B lymphocyte, T lymphocyte, and lymphoblast, which are the immature lymphocytes. The other topics will be discussed in our upcoming videos. So, let us see about the acute lymphoblastic leukemia. These are neoplasms composed of immature B and T cells, which are referred as lymphoblasts. This ALL is the most common cause of cancer in children. In ALL, we have BALL and TALL. This BALL comprises of 80% of the cases, whereas the TALL includes only 50%. The pathogenesis of ALL. In TALL, we have Notch1 gene mutation, whereas in BALL, we have PAX5, TCF3, ETV6, and REDX1 gene mutation. These genes are responsible for proper T and B cell differentiation and development. Other genetic aberrations in BALL includes hyperdiploidy and hypodiploidy. And also there is T9:22 mutation, which has this BCR-ABL protein, also known as Philadelphia chromosome, of 190 kilodalton size. The point to be noted here is, in chronic myeloid leukemia, we have this Philadelphia chromosome, but it is of 210 kilodalton. Let us see about the morphology of ALL. The bone marrow is hypercellular, packed with lymphoblasts. In TALL, we have the specific mediastinal thymic muscle involvement, and in BALL, we have lymphadenopathy and splenomegaly. In peripheral smear, we have this lymphoblasts. The nucleus composed of condensed chromatin, and the nuclear membrane has convoluted appearance, and the lymphoblasts have less conspicuous nucleoli and lacks granules. So this appears as hand mirror. Let's see about the difference between the lymphoblast and myeloblast. As we have already seen, the cytoplasm in lymphoblast is scanty and basophilic, whereas in myeloblast we have a moderate cytoplasm, which is eosinophilic. The chromatin in lymphoblast is condensed, whereas in myeloblast it is homogeneous. In lymphoblast we have less or inconspicuous nucleoli. In myeloblast we have prominent nucleoli. The granules and or rods are absent in lymphoblast, whereas in myeloblast the granules and or rods are the prominent features. Let us say about the clinical features. The bone marrow function depression symptoms. Due to less RBCs, the less RBCs are formed as the bone marrow is filled with lymphoblasts. So, due to less RBCs, there is anemia, which presents as fatigue. And due to less WBCs, we have the neutropenia, which presents as recurrent infections. And due to less platelet count, we have the thrombocytopenia, which presents as bleeding. The mass effects include bone pain, which is due to bone marrow expansion and subperiosteal infiltration. Also, there is generalized lymphadenopathy, splenomegaly, hepatomegaly, and testicular enlargement. Particularly in TALL, we have this mediastinal and thymic involvement, which are the complications due to compression of large vessels in airways in the mediastinum. The CNS manifestations include headache, vomiting, and nerve paralysis due to meningeal spread. Let's see about the prognostic indicators of ALL. The incidence between the age 2 to 10 years indicates good prognosis, whereas the incidence between less than 2 years and more than 10 years, and also in adolescence and adulthood, indicates worse prognosis. The low WBC count indicates good prognosis, whereas the peripheral blast count more than 1 lakh indicates worse prognosis. The hyperdiploidy more than 50 chromosomes indicates good prognosis, whereas the hypodiploidy indicates worse prognosis. Trisomy of chromosome 4, 7, 10 and T1221 mutation indicates good prognosis, whereas T922 mutation of 190 kilodalton size indicates worse prognosis. And finally, BALL indicates good prognosis and TALL indicates worse prognosis. So that's all about the acute lymphoblastic leukemia. Now let us see about the chronic lymphocytic leukemia. This CLL is also known as SLL or small lymphocytic leukemia. The CLL is the most common leukemia of adults in Western world. The incidence is commonly 16 years of age and it has a male gender predominance. Let's see about the pathogenesis of CLL, which includes the deletion of 13q, 11q and 17p, and there is trisomy of 12q. There is loss of tumor suppressor genes, which are 2 microRNAs, MIR15A and MIR16-1. This leads to overexpression of BCL2, which are the anti-apoptotic proteins. And also there is gain of function mutation in Notch1 gene. There is growth factor expression by the tumor cells, which includes the nuclear factor K beta and MYC. This NFK beta promotes the cell survival and this MYC promotes the cell growth. These two genes are the gene transcription regulators. And also there is mutation in signaling pathway, which includes the Bruton tyrosine kinase mutation. This BTK mutation causes increase in Bruton tyrosine kinase, which leads to increase in B cell count, which results in the increase in IgG antibodies. Let's see about the morphology of CLL. In lymph nodes, we have very small lymphocytes of 6 to 12 micrometer with round to irregular nuclei and condensed chromatin and scant cytoplasm. In peripheral centers, we have lymphocytes gathered in loose aggregates. And in peripheral blood smear, we have the characteristic smudge cells which are formed because the lymphoblasts lose vimentin and the cells become fragile and smudged on making the peripheral smear. This appearance is classically known as convert girl appearance, as all the lymphoblasts in peripheral smear look similar. The immunophenotypic markers include pan B cell marker, which is CD19, 20, 23 and CD5, and surface immunoglobulins include IgM and IgD, and also there is high level expression of BCL2, which are the anti-apoptotic proteins. The clinical features of CLL includes the non-specific symptoms, which is yearly fatigability, weight loss and anorexia, generalized lymphadenopathy and hepatosplenomegaly. The leukocyte count may increase up to 2 lakh per millimeter cube, and there is hypogammaglobulinemia, which leads to increased susceptibility to infection. And there is hemolytic anemia and thrombocytopenia due to autoantibodies by non-neoplastic cells. Let's see about the prognostic indicators of CLL. The deletion of 13q and deletion of microRNA 15 and 16 indicates good prognosis, whereas the deletion of 11q, 11p and TP53 mutation indicates worse prognosis. And also lack of somatic hypermutation and mutation in ZAP70 and Notch1 gene indicates worse prognosis. Now let's see about this Richter syndrome. In Richter syndrome, this CLL transformed to a rare aggressive diffuse large B-cell lymphoma. Here, there is enlarging mass within a lymph node or spleen is seen. This occurs due to mutation in TP53 or MYC. And that's all about the chronic lymphocytic leukemia. Thanks for watching. If you have any queries, mail us to the above mentioned Gmail account. And if you like this video, please subscribe and share it with your friends. Thank you.